are non-contractile cardiac cells. They are technically in 6 places, but 2 kind of together. It starts with the sinoatrial node. This is in the right atrium, just at the base of where the superior vena cava joins the right atrium. Okay. So this is considered the main pacemaker of the heart. So this actually will depolarize at 100 times a minute. Okay? At rest, without being stimulated. What is that? What's considered normal heart rate? 60 to 72 is considered normal resting heart rate, right? We don't consider, in terms of tachycardia, we talk about 100. So what's happening? Why is this, which is capable or which likes to depolarize at 100 times a minute, not doing it? Which autonomic nervous system slows down our heart? Parasympathetic. So parasympathetic actually slows it physically down. Okay? But this actually wants to depolarize it. Then the next part, we're kind of ignoring the pathway because they cannot self-depolarize. That's why we're not talking about that. But there is a connection between the sinoatrial node, the AV node, atrioventricular node. This is found on the right atrial wall, okay, on the interventricular wall itself. The AV node, we'll talk about this, this has 2 functions, okay. Yes, it's going to send the impulse to the next part, okay. What do you think AV node, what's the 2 connections? Atrium and then ventricles, right? The next one's very important function. It actually delays the impulse by 0.1 second. Why is it an important function? Yeah, because it said AV, right? So we want the depolarizations of the atria to occur first, so then they will contract, and then only we want the ventricles to depolarize so that they contract afterwards, right? Because they are both if they both depolarize at the same time, they're going to contract at the same time, which we do not want. Okay, so we'll talk about that too. Actually, let me go over each one separately. So sinoatrial node, it's the pacemaker of the heart. That's what actually sends the impulse. That's the starting point. Okay, and that I really wants to beat at 100 times a minute, or wants to depolarize at 100 times a minute. It's parasympathetic nervous system that actually reduces it. It spreads across the atria and then to the AV node. Okay? So AV node is the connection between that and the AV bundle. That's first function, but a very important function is this one. Delays the impulse. It says, okay, wait, and sends it. Just make sure that the atria depolarizes first before the ventricles depolarize. Okay. Then the AV bundle, let me go back to this image, okay, that's connecting the atria to the ventricles. And that's the only connection between the atria and the ventricles. Right? Why is that important? Electrical connection between the atria and ventricles. Why is that important? It's going back to the special structures of cardiac muscle cells. What's the special structures called which connect the 2 adjacent cardiac muscle cells? Intercalated disc. What are some features of the intercalated disc? They prevent from separating, that's the desmosomes. Next one. They have gap junctions, right? If there was electrical connections between the atria and the ventricles, what will happen? When the atria depolarize, what will it do? It will send it to the ventricle. Okay, so this does not. This says, okay, everybody has to come through this part, all the impulses. Okay, we'll talk about ectopic pregnancy, ectopic beats. that's when it's coming from elsewhere. Right? Ectopic basically means not in the right place. Right? That's the same thing with pregnancy too. We'll talk about it. Here, ectopic means it's not coming from this. There might be an area here where it's starting to, these normal cardiac cells have become now non-contractile. They're sending an impulse to, which is confusing, which we'll talk about. So that's an important feature of the AV bundle. It's also called the bundle of His. It's not a gender-related thing. It is actually a person's last name was His who described it. Right? So that's the reason for it. So it's another name for the atrioventricular bundle. So this, yes, the function is to transmit the impulse to the next part. You can also set depolarized, by the way. But very importantly, this is the only electrical connection between the atria and the ventricles. Because if there wasn't, then it'll just pass through. So there are no gap junctions between atrial cardiac muscle cells and the ventricular cardiac muscle cells. Right? They're not. It's the only way that they can depolarize at a rate of about 40 times. So if the SA node is not working, AV node will take over. That can be about 60 times a minute. If that's not working or it's uncoordinated, this one can also fire. Then it splits within the interventricular septum. They'll separate out into right bundle branch and a left bundle branch. If you've heard of bundle branch blocks, that's these bundles that actually blocked. Okay? You might guess where they're going. Right? They're going to that side, that ventricle on that side. So right bundle branch block, and bundle branch will supply the right ventricle, left bundle branch will supply the left ventricle. The next part is Purkinje fibers. Okay? This is what actually depolarizes the muscle cells themselves. And it's important from where they begin. It's from the apex upwards. Why is that also a useful anatomical aspect? But this is what's going to cause the depolarization and hence contraction of the ventricles.
On the left side of the aortic valve is more close to your side heart, so one side is back first, otherwise you're not going to get all that.
Yeah, it's the same for the right side too, right? So you want the blood to leave the ventricles, they leave it from the top. So you kind of, even that millisecond delay, you want the contraction really to start at the apex and then work its way rather than from up to bottom, which is where if the bundle branches actually innervated the muscle, that's what we want, right? Because the impulse is coming from the atrium. We don't want that. We want the ventricles to contract from the apex upwards. So it's actually these Purkinje fibers, which is also called subendocardial conductive system, which innervates the muscles of the heart. So it starts from the apex and then goes upwards. This will stimulate the ventricular depolarization and followed by contractions of the ventricles. Okay, just make sure that the contraction begins at the apex and works its way upwards. So blood vessels which will take the blood is superior. Any questions for that? Okay, so next are some terminology. Bradycardia, tachycardia, you would have heard, right? So anything less than 60 beats per minute is considered bradycardia. Anything greater than 100 beats per minute is considered tachycardia, right? It can be normal, physiological, and can be abnormal too, right? While extrasystole or premature contractions is because of ectopic focus. What that means is it's producing an impulse from elsewhere. Okay? So if it's producing the atria, it'll eventually get to the AV node and then has to go through. Okay? But what happens is the timing is off. Right? So this impulse is not going to be at the same time the SA node fires, so it's going to be later, which means one impulse has gone through, then the next one comes in, there is a refractory period, does not allow the impulse to go through. So the one that's coming from the SA node is also blocked, okay? Which is why patients will tell you who suffer with extra the ectopic beats, ectopic depolarization, they'll tell you, I feel my heart beating fast, or there's a loud thud or a very strong contraction. This is because we've skipped one beat, okay? Because an impulse came in too quickly that it could not depolarize again, and the next impulse that came in, the true impulse, was also blocked, which means that wait for the third impulse. So 1, 2, 3, the first one should have caused a contraction, the second one should have caused a contraction. But now first one did, the second one did not. Wait for the third one. So 2 beats later, so blood fills up more, so it contracts with a stronger force, and patients feel that. Okay. So yes, it's an electrical problem, but it does manifest itself with some of the symptoms. Okay. So delays the next. Let's talk about EKG or ECG. Okay, electrocardiogram. This one will be for Wednesday's lab, we'll do it next Wednesday. For Monday's lab, will be 2 Mondays' time. We'll look at that, right? So very important, you probably have taken some, but what we have to really understand is the electrical activity of the whole heart. So we're not seeing all the depolarizations, or we're not seeing individual depolarizations, right? Rather, we're seeing the whole electrical activity, right? Do we do 12 leads on the ambulance now?
Mhm.
I know there was change in the rate. I know initially we only did the 3, which was also used as a 6 lead, ECG is 2, and then we're going to change that. So we have placements 6 on the chest, right? 3 limb leads, with the 12 coming from angular of those 3 limb leads. That's how they do draw up the 12 leads, by the way, if you may not know that. So, what do these represent? That's what we're going to learn. We'll learn a little bit next lab. Some discrepancies, if you will, but you're going to really talk about that in cardio class, paramedic, I forget which number it is. In that course, I'll talk about more of the abnormalities you'll see. Right? So here we need to understand the principles and what they represent. Okay? So a normal EKG has P, QRS, and T. Okay? They are representing the electrical activity of the whole heart. Okay? So P waves, here's what they show. Kind of, yeah, it's actually after the SA node, it's the atria depolarization. Okay? So it's the depolarization of atria. Again, impulse first, then only contraction. So please don't put down in your if you ask what does the P wave represent, do not put down it represents atrial contraction. Atrial contraction will happen after this. Okay? So P wave is the electrical ECG is electric activity of the whole heart. P wave shows the electrical activity of the atria, and then or depolarization of the atria, which then the contraction will follow. Okay? Then QRS complex, the main reason for that is the ventricular depolarization. But what's also happening is atrial repolarization. Okay, depolarization is the stimulatory, right? Which will be followed by contraction, while repolarization is which will be followed by relaxation. Okay, so it's really because of depolarization of ventricles, but we also have, I didn't put it there for the conversation, but while T wave is ventricular repolarization, right? Atrial repolarization also happens during the QRS complex. Just because the ventricles are so large that depolarization kind of will take over when we are measuring the electric activity, that's what it's doing. Okay? But it's happening at the same time as the QRS complex. So this is depolarization of ventricles as well as repolarization of atria, QRS complex. Okay? While T wave is a repolarization of ventricles, which then follows, relaxation follows this. Any questions? So we can use it for many things. We can talk about the rate. We can talk about the voltage changes. For example, if I had pericardial effusion, my chest leads measurements will be low, okay, because they're not transmitting the impulse. The electrical activity is not very important. Right? So, for example, that can be measured. And you might have heard of one type of MI, which can be diagnosed on ECG. STEMI, what does it stand for? Yeah, it's ST elevation. So ST segment is between the S wave and the T wave. This flat line, if it's high up here and it's new, some people have this as a normal. If it's new, then chest phase, that's very likely to be ST elevation. We can measure that. We can talk about blocks. We mentioned bundle branch blocks. We can also see AV blocks, right? That the atrial SA node depolarization and the AV depolarization is not coordinated, hence the atrial depolarization and the ventricular depolarization are a little bit off sync. Right? And there are a few types of that too. Those kind of things can be measured. Right? So we do talk a few others, arrhythmias, prolonged QT interval. We can measure, what is AF? AF. Atrial fibrillation, which can be seen in ECG. Then the ones we don't really want to see, SVT or VF. What does VF stand for? Ventricular fibrillation. What kind of patient is in ventricular fibrillation? Did you see?
Cardiac arrest.
The cardiac arrest patient. We do have pulseless SVT, or people with SVT, supraventricular tachycardia, they do have pulse as well. See that as well. So yeah, and if you have a large R wave, that also means ventricular hypertrophy, which means it's taking a longer time to pass through, and so on, right? We talk about the ST elevation in mind. That can also be questions. We'll make sure, so for us, we'll do a 3-lead ECG, we'll analyze it just for practice, we'll count, we'll look at those segments, ST segment, PR interval, and so on. We'll try to work it out. It's normal, it's and so on. Next one, we're going to talk about cardiac cycle. This is talking about the activity in terms of contraction, relaxation of the whole heart. Okay? So first, 2 words. Systole versus diastole. Right? Systole refers to the contraction of the heart. Diastole refers to the relaxation of the heart. Okay? That's really the highlight of those 2 terms. How much do we need to know? Let me talk a little bit about them. First and foremost, we need to recognize that the atria need to contract before the ventricles. Okay? That's very important. We definitely have to know that. But also know, we'll talk about after blood pressure. Let me mention blood pressure first, okay? What is blood pressure?
The amount of force that the heart puts out, pushing that blood out, you can measure how much the heart is actually working when it's at rest and when it's pushing it out.
But where do we measure it? What? Yeah, it's actually the walls of the blood vessel, right? So we can relate it to the heart contraction, but blood pressure so just means pressure exerted by the blood on the walls of the blood pressure. When we measure the blood pressure, we generally measure the systemic arterial blood pressure, which should be the same as the ventricular, left ventricular blood pressure that can be felt, right? So, having said that, actually, let me rephrase that. So it's still the blood pressure in the blood vessel, right? Give me a blood pressure that you think is normal. That can be
110.
changed twice now in the last 5 years.
110/70.
120/70. Okay, let's take that. So 120, what is that called?
Your systolic.
Systolic blood pressure, and then 70 is
Diastolic.
diastolic. What is the diastolic blood pressure mean to us?
It tells us when the pressure is at when the heart's at
Yeah,
rest.
so again, where is this pressure?
In the veins.
in the blood vessels, right? So we are really talking about this 120/70, we're talking about in the aorta and the arteries, right? So when we fully relax the ventricles, pressure goes down to 0 in the ventricles, okay? So there is going to be a time, that's all I want to talk about here, is there is going to be a time, where is my isometric contractions? Doesn't show that. This image is not show it. Okay. So it's not close. So initially, when the ventricles build the pressure, you're going to have for a brief period, all 4 valves are closed. Okay. We want the AV valves to be closed whenever the ventricle contracts. That's given, right? But the semilunar valves are closed because the pressure, for example, in the aorta is 70 millimeters of mercury. Okay. So ventricles has to build up its pressure for it to increase to actually open those valves. Okay, so there is a time where there is pressure being built, there's contraction happening, but we do not pump blood out yet. Okay, so recognize that you might actually see it if you watch a echocardiogram. You'll see the contraction and then you'll see the blood flow. It will not be as soon as it happens because that's to build up the pressure to get it. Otherwise, everything else hopefully is straightforward, right? So we do have filling of blood to the ventricles even without arterial contraction. Okay. Why would the ventricles fill up with blood without arteries, without atria contract? It's gravity, right? Which one is lower? Ventricle. So gravity pulls some of the blood passively to the ventricles. That's what's shown here. Okay. There is a ventricular filling even before the atria have contracted. Okay. So here it shows about atrial systole, pushing blood into the ventricles, but before then, while they're still in diastole, some blood does go into the ventricles because nothing's going to stop the blood going down. That's another thing to also do. Now let's relate it to the sounds we hear. Okay? So what is the first heart sound because of? Of? Which one? Tricuspid, tricuspid. So the AV valves. What's going to follow the first heart sound then? Okay, let me ask you a different way. When would the valves have been open? When the atria are contracting or the ventricles are filling, right? It closes just before the contraction of the ventricles, right? So systole of ventricles occur after the first heart sound. We can know when it occurs. It's not, heart sound does not tell us it's happening, but it's going to happen afterwards, right? It's not, or rather I should say, heart sounds not because of the contraction. Okay, so valves closing, then the ventricles are going to contract. Where's the blood going to go? Out. So either in the aorta or the pulmonary valve, pulmonary vein, pulmonary arteries. What's the second heart sound because of? And those 2 valves closed. Now we have diastole of the ventricle. So we can time it up, but those sounds are not possible. We know what is happening related to those. Right? It is all, it's all working together. Any questions? Okay, so let's talk about now that how we're going to pump 5,000 gallons of blood in a day, right? So we have something called a measurement called cardiac output. So cardiac output is the amount of blood that's pumped out by the heart in 1 minute. Okay? So if I vary the heart rate, this may change. And you might guess it should increase. not necessarily, we'll talk about that in a second, okay? But what it determines is also it's multiplied by what's something called the stroke volume. Okay, stroke volume is the amount of blood that's pumped out in one contraction, one ventricular contraction. Like during one ventricular contraction, that's a stroke volume. Number of times it does that, which corresponds to the heart rate, right? Is going to give us, when we multiply the two, it's going to give us the amount of blood that's pumped out in one cardiac output. Okay? So stroke volume is roughly about 60, let's talk about what things affect her. It's about 60 milliliters in a beat. It's not very big amount if you think about it. Okay? So let's talk about things that affect it, right? So if we change heart rate, we anticipate that the cardiac output will change. Okay, I won't say proportional because it doesn't necessarily equate to it. We'll talk about why in a second. Okay. So what does stroke volume mean? It's how much gets pumped out, right? So is all of the blood that arrives in the ventricle pumped out? The answer is no. Okay. So there is still some blood left after the heart has contracted, after the ventricles have contracted. This is called end systolic volume, right? Because it's after systole. Okay. Stroke volume is basically the difference between what was there before the systole occurred and at the end of systole. Okay. So here it talks about how stroke volume equals end diastolic volume minus end systolic volume, right? If we change these, it will change stroke volume, and hence it can also change cardiac output, right? If there is a marathon runner amongst us, a trained athlete, if you measure their heart rate, what is it beating at? Slower. But does that mean their cardiac output's less? No. They should have the same cardiac outputs as a same sized individual who has not had training. Still, they will still have the same output. What's going to be different then? Stroke volume is going to be higher or lower?
Higher.
Higher, because lower heart rate, the only way you can achieve the same cardiac output, right? If I have a lower heart rate, this can only be maintained by increasing stroke. Okay, that's what they are does. That's why they're able to be at a slower rate, which means they have a better reserve. When they do exercise, they can build up their cardiac output to increase to even 30, 40 liters in one. Okay? No, it's not. Again, how much blood do we have in our blood, in our vessels? It's about 5 liters as an average, right? Which just becomes the same blood many times over. It's changing what's in it. So let's talk about this in perspective, right? So preload is something that's going to affect that end diastolic volume. Okay, so if we have more blood coming in, we're going to start off with a higher amount of blood. Right? What that does, this explains that ectopic beats I talked about, how they feel the blood. Okay, if my heart's beating slower, right? Blood does not stop from coming back to my heart. Okay, it's going to increase in the amount of volume of blood there. What that does to the heart muscle is actually stretches it, right? You can think of heart as a spring. Yes, it wants to contract, but if you stretch it out, it's going to contract even with a stronger force. Okay, so if more blood returns, they will contract with stronger force. This phenomenon is called the Frank-Starling law. If more blood is in the ventricles, they're going to stretch, they're going to contract with a stronger force, which means stroke volume will increase. Having said that, what do you think happens if my heart's now beating at 100 beats per minute, 120 beats per minute. What do you think about the filling effect?
It's gonna be smaller.
It's going to get smaller. Would that affect our cardiac output? It can, but we still maintain it. It's a different reason. Okay, we actually, our sympathetic nervous system will stimulate the muscles to contract with a stronger force. And hence, we do not have a smaller stroke volume. We actually have a good stroke volume, but we're still pushing a larger amount of blood. Each time we contract, even though we're getting less in, there'll be less remaining after the contraction, because we're still pushing more of the stroke. So that's how we maintain it there. So this is the contractility. So if we affect contractility, we can change the amount of blood that's moved out in the stroke. Okay. So the greater the contractility, that means the muscles will contract a stronger force that will result in a higher stroke volume. This is what our sympathetic nervous system does, because we increase heart rate, filling times decrease. So eventually, if we didn't have this, stroke volume will be less. Okay? But it's not less because of this. Okay? Which is why I was very careful of talking about by effect heart rate. It doesn't always increase cardiac output directly, because it actually will decrease our stroke volume. So cardiac output could be the same, could be slightly higher, or even lower than that. Okay? But because of this, our cardiac output is actually increased. We're able to keep it. Then let's talk about some problems if we had that's preventing from blood from leaving our heart. So called afterload. If I had pulmonary edema, okay, or rather, if I had aortic stenosis, okay. If I had aortic stenosis, that means I'm having difficulty moving blood out of my left ventricle. There's going to be back up. There's going to be a higher afterload, which means again, it's going to affect the amount of blood that flows through. That means stroke volume is going to decrease. Okay, so it reduces the ventricle's ejection ability. Okay, hypertensive patients. Why do they also have a lower stroke volume? What is hypertension?
High blood pressure.
High blood pressure, right? You can have both systolic and diastolic. Diastolic is actually worse for the heart, because as I mentioned, we have to build up the pressure before those valves open. So it's a higher pressure. So if I had 160 over 100, I'd have to get to 100 even before blood leaves my heart. Okay, so the pressure also affects it. So these valve issues can cause problems with affecting blood flow. So we have something called cardiac reserve. This is how much normally we contract, normal cardiac output, and then the most we can put out, right? Is that reserve. That's called the cardiac reserve. So we have roughly about 20, we can pump 20 liters in a minute. We're able to do that, okay, because of the cardiac reserve. But athletes will have a higher cardiac reserve, so they can even increase it by 25 liters. That's what training will do. Any questions? So, a couple of things before we start. Actually, I have 2 slides, and I'll just introduce the blood vessels. So we'll get into the nitty-gritty. I want to talk about some histology and stuff. Okay? So in terms of the autonomic effects, right? So normally we have parasympathetic innervation of the SA node, which slows down the heart rate. Right? Normally, if you let the SA node to beat for us at its normal intrinsic level, it will be at 100 times a minute. Okay? So the SA node can respond to acetylcholine and norepinephrine. Where is acetylcholine released from? Okay, where is norepinephrine released from? Sympathetic, right? So it's released from the sympathetic. So what releases acetylcholine? parasympathetic, amongst others, right? We looked at the skeletal muscle, the motor neurons also release acetylcholine, but here too, acetylcholine release, and here it's the parasympathetic cortex, right? So it will slow down the heart rate, right? Parasympathetic slows it down, while norepinephrine will increase the heart rate. First, initially, we'll just take off that brakes that the parasympathetic is putting up, so quickly it will climb to 100 very quickly, and then it starts innovating to needs to climb further. Okay. So, if we, the reason why I mentioned this in endocrine system too, we get frightened, our heart rate goes up because of our sympathetic nerves, but our heart rate remains high. Why? It's the endocrine system, right? The adrenal medulla, which has also released norepinephrine and epinephrine, right? So this one will have that sustained effect, even though now the impulse has gone away, but there is a long effect of this action, of this innovation. The next thing I want to talk about is failure. Okay, when we say right-sided heart failure, right? So that means what to us? First of all, what's happening? What's not happening? Left ventricle is not pushing out, right? So if the left ventricle is not pushing out, blood backs up. Where would we get fluid collection in this patient?
For right-sided?
Yes.
Pedal edema?
Yeah, why? The pedal edema, does everyone know what that is? Fluid cooling in the feet first and then starts rising, right? Pedal pedis, right? Why does it cool there first? Gravity, right? Generally, we're talking to people who are standing, they're lying down, it's going to be actually in the back, you'll see it. But it's because of gravity. The veins is where it's backing up into systemic veins. That's where the most of the gravity will pull, so they leave the blood vessels, right? So there's fluid, extra fluid in the interstitial. While if I had left-sided heart failure, where would the blood back up and where would I have fluid?
Pulmonary?
In the lungs, right? So this is quite obvious. If you see a symptom and you think heart failure, you can actually diagnose which side the heart is not from the symptoms, right? So left-sided heart failure, we have pulmonary edema. Right-sided heart failure, we have edema in the systemic, usually noted in the feet. If it's someone lying down, bent down, you want to check that back sacral region, that's where it's included. Edema there. And then tachycardia, because there's less fluid flowing, the heart's not pumping well, so both individuals generally have tachycardia. Here they have dyspnea because there's fluid in their lungs. Questions? Okay, let me do just a little introduction on, because we have fallen a little bit behind. Types of, I'll leave the capillaries for Okay, so let's talk about blood vessels, right? So cardiovascular system is considered a closed circuit, right? What about lymphatic system? Does anyone know? It's considered an open circuit. You have to leave the lymphatic to get back into it. As cardiovascular system, these can remain in the blood supply, right? So let's talk about the blood vessels. So first we'll start with the arteries. When they leave the heart, blood vessels that take blood away from the heart are called arteries, right? The biggest artery in our body is the aorta, right? That's still an artery, just has a different name, but it's still an artery, okay? And then it'll go down, it'll get smaller and smaller. We'll talk about the 3 different levels, if you will, of arteries today. And then it'll get to the capillaries. The 3rd level being the arteriole, okay, and then it gets to the capillaries. What's the structure of the capillaries? It's very thin. How many layers? Just one layer, right, of simple square. It's simple because one layer swarms everything. That's where gas exchange takes place, right? And then it starts building up to larger blood vessels. So we call them venules, and then to veins that get larger and larger. What are the largest, if you will, of our veins? Even bigger than superior and inferior vena cava, they're the largest of veins, right? They will drain into which side of the heart? Right side to right atrium. So it's considered closed circuit. Right here, the green shows an open circuit, so it's from tissues, it's going to take fluid back into the blood supply, but it does not come back in the same system. We talked about pulmonary circuit and the systemic circuit. Let's move on. Let's talk about the walls of the blood vessels, right? So we're going to start with the lumen, work our way out. We're going to talk about endothelium first. That's going to be part of tunica interna. Tunic means layer, okay? So here it's not just the endothelium, there's also connective tissue. Why does there need to be connective tissue next to endothelium? Next to any epithelium. Blood supply wide. There are 8 vessels, right? So we'll talk about it. Tunica interna. It's got to have it'll have the connective tissue too. Then it's tunica media, that's the muscle of the blood vessel, and then tunica externa. This is absent in the capillaries, but everywhere else we do have it. Just the thickness and content might be slightly different between, especially between arteries and veins. Okay. So let's talk about them. So the tunica interna, there is an endothelial layer, which is the simple squamous epithelium that lines the lumen of the vessels. And then we have some connective tissue. In tunica media, the most important thing is the muscle, which can respond by either constricting the blood vessel or dilating the blood vessel. Ooh, hypertension. Is that because of constriction or dilatation of the systemic blood vessels? Constriction. You think of it as if you open a faucet, water is running through. You put your finger in there. What's happened to the pressure of the water? You're covering part of the orifice of the tap. It increases, right? So constriction, it actually causes blood pressure to increase. So this can respond to nervous system stimulation and can vasoconstrict or dilate. Tunica externa also has extra connective tissue, which helps to kind of bind this, connect this vessel to other structures. Right? What does the elastic fiber do? Dense elastic connective tissue, for example. Questions recall, right? The large blood vessel will have a lot of that. It's in tunica media mostly. There's a little bit within tunica interna. So let's talk about the difference between arteries and veins. We talked about one difference. What was that? Yeah, so it brings blood away from the heart, arteries, towards the heart veins. Then you look at the wall thickness and the lumen. Arteries have a thicker wall because blood is flowing at a higher pressure. Okay? On the same side, artery and veins, if you have a thicker wall, what about the lumen? It's going to be smaller. So arteries, comparative size vessels, arteries have a smaller lumen but a thicker wall. Okay? Veins have valves. What do valves do?
Let blood go one way, not the other.
Yeah, they prevent backflow, right? So veins, because there's no pump, it has to be kind of milked up. We'll talk about it in that sense. It has to be moved little by little. You don't want it to come back down, especially in the legs where the gravity will try and pull it back down. Okay? So let's talk about the 3 types of arteries. This is what the last topic we'll talk about. Okay? So the first one, if you talk about aorta, that's the first type. That's the elastic arteries. What does the name kind of tell us? Yeah, it's got something elastic. So it's got some elastic fibers. This is where the pressure is the highest. Okay, that's why we want to be able to understand that pressure changes. Right? So these are the thick walled aorta, pulmonary trunk, for example, where pressure is the highest. These are elastic arteries. The next ones are called the muscular arteries or distributary arteries. These are called conducting, because they're taking the blood away from the heart. Okay? The other ones are called distributing, because they're going to go into the liver, the kidney, the stomach. Okay, so all our named blood vessels, those are part of this muscular arteries, these distributary arteries. Hepatic vein, so hepatic artery supplies the liver. Renal artery supplies the kidneys. These are muscular arteries, okay? As well as they're also called distributary arteries. They have the thickest tunica media, because in that is the muscle, right? It is called muscle, and this helps with vasoconstriction. For example, when we have sympathetic nervous system being firing, we have blood supply to the kidneys are going to go down, blood supply to the liver is going to go down. Pretty much all of the abdominal organs. Where will blood supply increase? So it's not decrease to everything. It will increase to the brain, cardiac, heart, and to skeletal muscles. Why? What is our sympathetic nervous system also referred to as?
Fight or flight.
Fight or flight. So those are the organs we need for those purposes, right? So they can adjust. The last ones are called resistance arteries or arterioles. They're called resistance because they can cause the biggest change in blood pressure. Okay? This is where the biggest drop in blood pressure happens because of the way they can vasodilate and constrict much stronger. This is the difference. Okay? And that will change how much blood is going to be supplied. The next component, which is the capillaries. Okay? Picture. Let's talk about aneurysm and then problems in blood vessel, right? So what's an aneurysm? Balloon. So the walls of the vessel is thinned out, it does balloon out, and is it dangerous if it ruptures? It can be, depending on where the blood vessel is, right? What does AAA stand for? So, abdominal aortic aneurysm. That's an emergency, right? It's a big blood vessel. If that bursts, a person can be impacted in a few, depending on how much, usually not minutes, but usually a couple of hours. Perish right? So it's the thinning of the blood vessel wall, and hence it balloons out. There's a high risk for hemorrhage. Okay, so brain, talk about the two types of stroke. This will be which one? Hemorrhagic stroke. Maybe depending on where it is and how big the aortic aneurysm is, can have within minutes, tens of minutes. The last thing I want to talk about is arteriosclerosis. This is the hardening of the blood vessel. Okay. Here it is. Does anyone know what triggers the start of it? We always talk about what's found in it. We talk about calcium deposits. We talk about fat being in it. What actually triggers it? There's been a lot more information that's been researched and shared. It's just inflammation of the blood vessel. Okay? If someone who suffers hypertension is at a high risk for that, because the blood vessel now has to cope with a higher blood pressure, so it's going to get injured more easily, which means inflammation, which is basic response to any injury first, right? Just kind of segregate that area. That starts off, and then sometimes calcium deposits go there, fat goes there, and then it blocks the blood vessel, the wall, not necessarily thickens is the right word, kind of comes inward with all these deposits, reducing the lumen and hence causing blockage. Right? So some reasons are diabetes, obesity, smoking does, hypertension can cause it, but also it results in hypertension, right? Because it's now smaller blood vessels, so the pressure is also higher, which again aggravates or speeds up atherosclerosis. Any questions? Thank you. The first chapter I go through was a lot information you probably heard, so I'm going to do it a bit. Have a wonderful day.